Up next, Clyde Yancey is joined by Dr. Christopher O'Connor, Chief of Cardiology at the Duke Medical School in Durham, North Carolina. They cover diastolic dysfunction. Should prognosis and management be focused on comorbidities?
Chris, welcome to ACCEL.
Clyde, thank you. It's a pleasure to be here. Exciting times in heart failure, especially preserved EF heart failure.
When we think about where we are with HFrEF, or reduced EF heart failure, indeed there are exciting times, and we've got the opportunity to introduce a brand new concept into the treatment paradigm, using paradigm deliberately now, and can maybe realize better outcomes with now an RNA plus beta blocker, device therapy, etc. But we haven't had that same sort of robust discovery yet with heart failure with preserved ejection fraction. So let's talk about three things that I heard you highlight today. First was the heterogeneity of the disease. Second was a new way of classifying the disease. And the third part that I thought that you did quite nicely was to tease out a couple of signals that say, we may already be onto something that could work here. So let's start with that approach.
No, I think that's exactly right. The disease state of HFpEF perhaps is harder than HFrEF in the sense that there's multiple pathophysiologic components that result in this clinical condition. And we get the added challenge of more and more complicated comorbidities that actually are more toxic to the HFpEF patient than the HFrEF.
You made one point that I thought was emphatic. You said for HFpEF, this may not just be one disease, whereas for HFrEF, at a certain point in time, it's just reduced EF heart failure, and we treat it all the same. But I thought that was a really great point.
Yeah, and I think that's why we've been looking at ways, and your team also has been doing this, looking at ways to, can we do a better job of classifying this condition? Obviously, lots of patients, 50% of the admissions, 50% of the population now, we believe have HFpEF, aging population, more HFpEF in the aging population. Are we really smart lumping this all together? Look what the oncologists do. They phenotype, they genotype, the biomarker type their patients, and then they get signals in those subgroups, and they move the therapy forward. And we're trying to take this whole complex condition with complex endpoints that are non-cardiovascular and say, can a cardiovascular drug provide benefit? And we're seeing attenuated results. And I see signals in there, but I think people are discarding them as pure trialists.
So let's talk about the things that we are doing with regards to getting away from just using gender or age or disease etiology to define HFpEF, and taking an agnostic view and taking all the phenotypic markers and putting them in a big bucket and seeing how they shake out. You show some pretty interesting data that something that we'll just call category 4 seem to respond very differently than categories 1 through 3, correct?
That's right. In this cluster analysis, this is an unbiased way to group similar patients based on characteristics and outcomes that are triaged, and not having any biases going into that. One can develop groups of patients that are very different than the way we normally think about our patient classification. And so it's elderly men with lots of comorbidities, ischemic etiology, young underrepresented minorities with hypertension and certain types of comorbidities, and then women with a few comorbidities. And we looked at these clusters and looked at the outcomes, and we saw different outcomes, and then we saw a different response to exercise. And that was fascinating. And I say, for the first time, we're starting to see signals where NYHA class stage is not enough.
So I completely agree. And I remember when we saw the results of iPreserve, and we all just sank and said, oh my, another negative trial. But the important message that the principal investigators articulated at that time was simply this: it's time to pause and try to understand either more about this disease or understand it differently. And I think what you're doing with these cluster analyses is part of that difference that needed to happen. Let's transition now to the signals that you think are already embedded in the literature that suggests that maybe not at the tier of guidelines, but there may be something there. Signals with RAS blockade, signals especially with aldosterone antagonism.
Well, that's exactly right. I think if you take the PEP-CHF trial, ACE inhibitor trial that John Cleland ran, and then you look at CHARM with candesartan, and then we'll go to iPreserve. PEP-CHF showed a statistically significant benefit on heart failure hospitalizations and death at 1 year that went away on their primary endpoint, which was great at 2 years. The reason is that in HFpEF, there's lots of crossover of cardiovascular drugs, dropping in, dropping out for hypertension, for angina, for AFib, and adherence is a bigger problem in the elderly with comorbidities than it is in young people. So that was a big problem in that trial, just like we talked about with exercise. In CHARM, it actually turns out if you do an analysis of total heart failure hospitalizations plus death versus time to first hospitalization plus death, the drug is highly statistically significant in HFpEF. That's a good finding, and that's a more meaningful endpoint. We got the endpoints wrong. We've been doing the endpoints wrong, so that's a trial design issue. And iPreserve, there's some signals in there also on people who are naive of beta blockers and naive of ACE inhibitors. A third of the patients were allowed to be on ACE inhibitors in iPreserve. So the design was muddy.
Remember, iPreserve also taught us that there is not equivalency of diastolic dysfunction in HFpEF.
Yes.
We have to be very sharp about how we position those concepts. And then we have the TopCat data.
The TopCat data, I think, is really fascinating, and I think this is where I think the guidelines committees should come out a little stronger going forward and when they really look at this data, and that is that we've known that whether it's pre-specified or not, it should be in all trials that there's geographic variation to treatment response. And that has to be put up front, particularly when you go into countries that are Eastern Europe, Russia, and as we expand into Asia for our clinical trials.
And you also made the point, though, that there may be a way to obviate all of that, because there's obviously going to be some tension when you're talking about geographical differences and quality of care and standards of care, et cetera. But the group that fascinated me was the group that was identified based on a biomarker profile.
Yes.
Because that's irrespective of geography.
That really is. And that perhaps tells us that the definition of HFpEF in different parts of the world is either tighter, stricter around the heart failure symptoms itself, or looser. And so what happened in the countries that couldn't afford the natriuretic peptide or wasn't paid for or mandated by the trial, they used the heart failure hospitalization criteria to get into the trial. And hospitalizations in different societies, thresholds can be for many different reasons.
So let's just be certain we capture this on tape. What we're saying is that for those patients where an elevated NT-proBNP identified the significance of their heart failure syndrome, coincident with heart failure symptoms but an ejection fraction greater than 45%, there was a signal, we say this tentatively because it's a secondary kind of post hoc analysis, but there was a signal that those patients derived benefit from being on the mineralocorticoid antagonist. And so that's why we're having this conversation.
That's correct.
As we start to put this together, what we're suggesting is that the sense of futility may not be fully deserved with HFpEF. We're getting to know more about this condition, but know more about it in a different sort of way by getting away from traditional descriptors and looking at a different approach, these cluster analytic techniques that we've been discussing. And we may see that certainly if there's another reason to use a RAS blocker, definitely consider it. And it could be that if the syndrome is characterized by an elevated biomarker, then using the aldosterone antagonist might work. I want to close up by, first of all, making certain that I've represented what we talked about correctly there.
Yes.
Okay.
Yes, very much.
I want to close up by taking a forward view. We're all excited about Paradigm HF using this ARNI compound, angiotensin receptor antagonist plus neprilysin inhibitor. You talked about the Paramount data, and I also talked about the Paragon data. Just very quickly describe where we're going with this.
The phase 2 study in HFpEF with LCZ, this ARNI compound, suggested that there was indeed a significant improvement in natriuretic peptide levels, NT-proBNP, a greater reduction than in the comparator arm. That's nice because that's an emerging surrogate that we're starting to believe in. There are also softer signals too with New York Heart Association class. Some of the echocardiographic parameters look favorable. And so now going forward, doing an outcome study with this compound, taking the lessons learned from the journey of our previous trials, making sure there's a natriuretic peptide inclusion criteria, making sure that we're not letting patients in who don't have that kind of criteria. And really going forward, I think, is the hope for HFpEF.
And so we can be complete. You made the point opening, and I think this is the right way to close, that for right now, the strongest statement in our guidelines is treat the comorbidities first when you see someone with HFpEF, and you really emphasize that nicely. But let's reserve hope, because it looks like with different definitions, with drugs that we already have available, looking at certain signals, and with new trials coming forward, we may be able to finally crack the nut of HFpEF.
That's correct.
Thanks so much. It's great talking to you.
Thank you.